here tonight. No fighting.
We got the refugees.
No fighting.
Hi, I'm Professor Squid and this is Associate Professor Biles. We are here today to speak about the intriguing research we found about a structure that has only recently come to the attention of physicians. It is the ligamentum teres. This presentation will run you through the basic anatomy and biomechanics of the ligament, along with how it is typically injured, the rehabilitation process, as well as the surgical procedure endured to fix any issues associated with it.
Enjoy. Hey guys, I'm Dr. Abigail Lemos. This is Dr. Olva. We're here to talk to you a bit about the biomechanics and anatomy of the ligamentum teres. But just before that, I'll just give you a brief overview of the actual hip joint. So the hip joint is a synovial ball and socket joint. It's formed by the concavity of the acetabulum, which is formed by the pubis, ilium and ischial bodies. So just going on to the ligamentum teres, it's an intracapsular ligament. So it arises from the transverse acetabular ligament, which joins the two bits of the acetabulum through here. So it arises as a pyramidal sort of shape, you would say. And then it ends up as a sort of like a round ligament and attaches to that fovea capitis right there. The ligamentum teres, as I said before, it's an intracapsular ligament and it's an important stabilizer for the hip in the position of less stability. So it stabilizes the hip particularly in adduction, flexion and external rotation of the hip. Ligamentum teres, there are a few theories as to the function of it. In children, it's mostly that it transports blood vessels and nerves through the ligament to the femoral head for growth. Another theory is that it helps with nociception and coordination of movements, as it's got some receptors that transmit afferent signals from the femoral head to the central nervous system. And lastly, as I said before, it limits movement of the hip in adduction, flexion and external rotation, which is the hip's most unstable position.
It is only recently that medical research has explored ligamentum teres and injuries associated with it. Scientists found that ruptures to the structure are the third most common hip pathology associated with arthroscopies. So how does this structure get injured? There are three types of injuries that commonly occur to the ligamentum teres. A complete rupture can occur, and this usually occurs in those with a history of trauma. There's partial rupture, which usually occurs in patients with a long history of symptoms and chronic vague hip pain. And the last one is a degenerative change, which usually is associated with osteoarthritis. Two separate studies were conducted to analyse the prevalence of ligamentum teres ruptures. The first study concluded that 20 out of 472 hips had a form of injury. Another study showed an astonishing 41 out of 271 ligamentum teres ruptures. All of these recorded injuries were presented to the practitioner with groin and or thigh pain, along with additional symptoms of a limp or clicking whilst walking and especially running. Of the 41 injuries seen in the secondary study, it was found that 23 of them were due to major trauma and severe twisting injuries. As mentioned earlier, a common mechanism of injury to the structure occurs when a person falls on an ipsilateral knee with hip flex. This results in a flexion and adduction stress, a position which checks the ligaments, or a sudden twist into external rotation. In addition to this, it is extremely common for the ligamentum teres to rupture following a hip dislocation.
Now, when the ligamentum teres is torn, patients develop subtle hip instability, known as microinstability. Microinstability is aggravated by sporting activities such as running, footy and tennis. It can also lead to damage to the labrum and cartilage. This characteristic explains the high rate of association between a torn ligamentum teres and the labral tears and cartilage lesions. The most constant and consistent implication associated with damage to the ligamentum teres is hip pain. This pain can radiate to the inner thigh as well as cause discomfort in the groin region. The pain can also be associated with a feeling of hip instability and maybe further symptoms such as painful clicking, locking and giving way. Initially, the pain might be an ache, but it does progress in severity to become more and more painful. and can be aggravated by movements involving flexion of the hip, such as climbing stairs, deep squatting, doing up your shoelaces, picking up things off the floor. Additionally, the hip instability following a ligamentum teres rupture means that the hip may become prone to subluxation or dislocation. Contrarily, in some cases, the torn ligament has been observed to heal spontaneously. Risk factors for a ligamentum teres rupture include activities which require a wide range of motion in the hip, example in the ballerinas or in athletes. It appears that forced external rotation of the hip with or without flexion and abduction put the ligamentum teres under stress and hence are likely to increase the risk of injury. The incidence of a tear also rises with age, even within young adults. The bony structure of the joint itself is also very relevant. It has been reported that a lower centre edge angle and a higher acetabular inclination angle are both associated with an increased risk of tears. As you can see, this is the centre edge angle between the femoral head and the acetabulum. Additionally, acetabular retroversion is also associated with higher rates of tears. Acetabular retroversion is where the alignment of the mouth of the acetabulum does not face the normal anterolateral position, but inclines more posterolaterally.
I'm Dr. Reid, and today I'll be explaining the rehabilitation process of the ligamentum teres. So reducing weight bearing is really important, and the patient may be prescribed a walking device such as crutches, and just to take the compressive strain off the ligament. Reduced twisting movements of the hip is very important, especially external rotation, which is where the ligamentum teres is mostly taught. Strengthening surrounding hip and trunk muscles is very important as well, and this is to enable normal gait pattern and also to act as a protective barrier for the hip joint as well. And the patient can be taught these muscle exercises at home. So today I'm going to be walking you through some rehabilitation processes that you'll go through. So I'm going to be taking your hip through some ranges of motion just to get the movement back in there. And also I'm going to be doing some isometric exercises as well. So for example, I'll get you to push up into my hand. And these movements are really important to build up the strength of the surrounding hip muscles. So the important muscles to improve the strength are the quads, the glutes, hamstrings, the adductors and abductors of the hip, as well as building strength through all ranges of motion as well. Swimming is very useful for rehabilitation post-surgery for the ligamentum teres. So I'll just get you to do some marches. So balance and proprioception exercises are also very important, such as practicing standing on one leg. So once your strength builds up, you can do some low impact exercises, such as doing exercises in the swimming pool or on a stationary bike. And your rehab is very variable, but it should take about 4 months.
Hi, I'm Dr. Olga, and I'm going to take you through the surgical procedure of the reconstruction of the ligamentum teres. An anterolateral portal and a mid-anterior portal are established, and a diagnostic arthroscopy is performed to assess the whole joint. If the ligamentum teres, which is usually here, is completely torn, the stump in the acetabular fossa is cleared with an ablation device. So the graft can be made from either the patient's semitendinosus muscle or from a donor's tissue. Okay, drilling of the acetabular tunnel is performed through the femoral tunnel with the hip internally rotated and abducted to achieve correct tunnelling position in the cotyloid fossa. To maintain a safe distance from the obturator vessels, the tunnel is placed slightly posterior to the centre of the base of the fossa. Tools called knot pushers are then used to lead the graft through the 2 tunnels into the space where it needs to go. Once in place, a fluoroscopy is used to ensure correct positioning. The tools are then all removed and an arthroscope is used to examine the hip through its full range of motion. Once satisfied, the tissue from the graft is cut flush and the portals are then closed.
On behalf of Dr. Squid's medical team, we'd like to say thank you for watching and I hope you learned something. We'll see you next time.